Thank you so much, respected chairperson, for your kind words. When Madam Jain orders, we are from the time from Lady Harding. So हम नींद में भी भागे चले आए. And all the audience, I bring you good wishes for Holi and Women's Day. Although I have started feeling personally, madam, that why should there be a Women's Day? We should be stronger. We should celebrate a Men's Day someday. So that is my real original thinking. Maybe the day comes. So today we are going to discuss something about PCOS. And PCOS is such a vast thing. There are so many theses, there are so many patients. But today I am going to discuss something on hyperandrogenism, concentrating on hyperandrogenism in PCOS. So, just in the next few slides, so as much as that in the definition of PCOS has changed so many times, Notre Dame, Fresh, Eshrey, ASRM, because entity is still not very well defined. You will see a colleague will say this is PCO, other will say not, because there are some full-blown cases of PCOS where there is no problem. But there are so many gray areas. Somebody has just morphology, somebody has irregular periods. So now, in recent definitions, it's very important to incorporate either clinical or biochemical hyperandrogenism in the definition of PCOS. Well, India is always ahead and not in the matter of PCO also. So it's very, very common. Southeast Asia, India, it's much more common. And such high percentage of adolescents and adult women are suffering from PCOS. I personally feel it's a kind of lot to go with lifestyle disorder. Gone are the days when we were young girls going on a cycle to college and school and playing in the evening in the playgrounds and helping in the household work. Now the things are totally changed. The physical activity has gone so much low down and we have too much to eat. So these are the two reasons that PCO is becoming so much commoner. See the young girls, they are brought by their mothers, they are so overweight, and when you talk to them, what is your diet? I don't eat anything. Then the mother just says she doesn't eat house-made, homemade food. So there are so many ways they present, but it is ultimately calories and the wrong kind of food, which are two important factors. As I said, PCOS is a heterogeneous. It's multifactorial. Sometimes genetic, sometimes environmental, sometimes everybody who puts on too much of weight, 70% ovaries will become PCO. So, and some cases are classical and some have only one or two features. So when you start projects, research projects and all, it's very important which patient you are including according to inclusion criteria as PCO. Otherwise, there won't be much meaning of what results you are taking out. And as I said, today I'm going to discuss the importance of hyperandrogenism in PCOS. And the first thing is, any lady coming with irregular periods, don't label her PCOS because many cases are premature ovarian insufficiency, which will have hyperandrogenism, either clinical or biochemical, has to be as important, criteria for PCOS. So when we discuss that hyperandrogenism is very important for classifying or being a part of PCOS, and I won't go into all this. Everybody is after lunch and you will go to sleep, pathophysiology. But it is always chicken and egg story that whether it is hyperinsulinemia leading to hyperandrogenism or hyperandrogenism leading to hyperinsulinemia, we all know they both are there in these patients. Apart from clinical signs, a clinician is interested what patient is complaining and how you have to relieve. Hirsutism, acne, alopecia, acanthosis nigrans, and insulin resistance, and of course, anovulation, which thanks to infertility IVF, everybody is a master. So, again, these are the mechanisms and We also were fortunate to conduct so many trials on PCOS. So you have to score these patients. How much is the hirsutism score? Otherwise, patient will never agree that she has improved on your treatment. So take photographic. How much is the hair after 6 months? How much is the reduction in size? And these are the ways to measure properly. This is very important. Lot of these patients are not treated by us. They are going to derma colleagues, and you will see they have very different prescriptions. Derma people are interested only in the skin, and they mostly give local, put this, and we people, we want to revert that metabolic disorder. So we both have to work in cohesion. But for gynecs, I want to make a request that acne, we have much simpler solutions for many patients. Start taking it in your armamentarium. Don't send them to derma. These are the mechanisms. Androgenic alopecia, this is also, it's a typical alopecia. It is not the receding hairline, it is in the center of the vertex, and that is a very typical, and you will see in full blown cases it's very common. And of course, anovulation is the hallmark. And now there is so much of infertility. And when I was a resident, we used to have every other patient wanting MTP because no TV was there, no other recreation facility, and they were getting married early. And now they are married, you talk to them, they are in late 30s, and still they haven't made up their mind. And one day they decide we should have a baby, and then they come, and so many are anovulatory, many of them PCOS, which is really in ART, very difficult to take care. So, after discussing these common issues of hyperandrogenism, it's not only hirsutism, it's acne, alopecia, acanthosis nigrans, which is associated with hyperinsulin. Now, as clinicians, you are interested in knowing what is the best way to manage these issues as a clinician. So, this is the algorithm. Basically, I am not going to say anything new. You all know that for hyperandrogenism, combined oral contraceptive is a very good option. And which combined oral contraceptive? Everybody knows that cyproterone acetate is a OCP which has progesterone as anti-androgen, and it is proven in clinical scenario for decades that it's quite effective, and that in the next few slides we will discuss. So OCPs are the first line, and then I'm opening a Pandora box. Metformin. Literature is not yet clear which patient will be benefited by metformin, which will not, whether you should give to a particular patient metformin. I'm not going to go into it. My simple topic is how, in an easy way, to manage your patient of hyperandrogenism. So, most important, as I said, PCO patient comes to you, they are heavily built, they have hirsutism, they have anovulation, they have oligomenorrhea, and you have to tell them the lifestyle. Lifestyle changes are, it's not only just dieting or going and getting enrolled to a weight loss clinic. That is what I have seen in my practice. They just go for 2 months, they come back, and then they say that nothing happened, I'm back. It has to be incorporated in day to day life. I think more important than diet is the physical activity. We are totally becoming inactive. Just remember, you sit in a car, you reach your office, nobody is walking. So these are the issues, and we are not realizing that we have remotes, we have everything comfort, and that is the reason our mobility is so much less. So it's very important to increase physical activity. Diet should be more of protein, less of carbohydrate. Saying is very easy, doing very difficult. I also had nice gulab jamun and jalebi, and I was seeing JB also having that. So only Pratap didn't have. So see the degree of discipline and the dimension. Everything is proportional. So there are many other benefits of oral contraceptives, like they regulate the periods from the first cycle on. They are contraceptives. I am practicing now in city of Gurgaon, and I hardly see any girl who is virgin. And I don't think anything wrong. I'm just sharing the fact. So, and what these OCPs are doing, why these OCPs are so popular for as a prescription in a patient of hirsutism, because they have two components, estrogen and progesterone. Estrogen components leads to all this. Basically they increase serum hormone binding globulin, so that the free testosterone is less in the body, estrogen progesterone both. And if the testosterone is less, free testosterone, logically hirsutism will be less. And apart from that, they have all the other mechanisms which I am not going to go into today. Now, which OCP is best if a patient comes to you with hirsutism? She may be having PCO, she may not be having PCO. Any girl who complains of hirsutism, the cyproterone acetate containing OCP is the best option, as the evidence says in this present age. We are from the generation when cyproterone containing OCP was not available in the market. We were writing cyproterone acetate in reverse sequential form in the dose of 20 milligram, that high. That is another thing. Such little dose may be so much, sufficient, but sometimes we overdrug patients. And when these OCPs came, it is just 2 milligram of cyproterone. So that is something which we all should remember, that this little dose is enough. And how other actions of cyproterone, basically for testosterone to work on your hair follicle and make them millish or hirsute, it has to be converted into dihydrotestosterone by a hormone called alpha reductase. So cyproterone blocks alpha reductase and acts directly on the hair follicle, blocking the action of dihydrotestosterone, and that is the way it takes care of hirsutism. So there are so many clinical trials in the literature. See, once I say this is a good drug, then I can't say that I am telling this is a good drug. You will ask me, what is the evidence? We are in the era of evidence based. And now in the next few slides, we will just see the evidence in the literature that which anti-androgen containing OCP or which drug is good for treating hyperandrogenism and hirsutism in our females. So it is considered the gold standard. These are the generations of OCP. We are from the generation when we had first, second, we were not having. Now the Dinogas containing is available. Now this drosperinone containing, they have come in the last decade only. And these are all old progestogens were androgenic, affecting metabolism. These two, three are including cyproterone, anti-androgen, anti-metabolite. So they have, these are very good properties. Anti-androgen is very, very welcome. So cyproterone has the greatest anti-androgen activity of all progestins. And this is a very important piece of information. Anti-androgenic activity of drosperinone, dinogest is 30 to 40% of cyproterone. These are the studies. They show that cyproterone acetate has maximum anti-androgen action in clinical trials. So once we are convinced, now let us see what is the Indian consensus, and we are not far behind. When I was president, we started to baby steps that we should have our own Indian guidelines, and I'm very happy it is being continued. But we will really have to, what guidelines we are making, we are just sitting 2 days having some good time. We really have to threadbare discuss things in our scenario, what exactly is required. But there are good attempts by different Indian societies to make guidelines for management of PCOS and hyperandrogenism. So these are the various non-contraceptive uses, like again I said, acne, hirsutism, alopecia. This slide may be of importance to you. When we say you have decided this girl is hirsutism, then you want to give her OCP containing cyproterone acetate, then the things come in your mind. What are the investigations I should do? For decades, WHO and we are teaching, in a healthy person, You need not do many investigations to prescribe OCPs, otherwise the meaning will be lost. As such, it is so difficult to, sometimes you feel like you are a salesman if you are advising for contraception. They are such literate girls. The moment you utter hormones, no, 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 they will go for multiple MTPs, but they don't want to take OCPs. I don't know. We are not able to break that myth completely. So the question was, the clinical issue was, what should be the investigations before you prescribe somebody for hirsutism or alopecia or the acanthosis, cyproterone containing OCP. And this is a very good literature review done by our Indian colleagues, two societies, FOXY as well as Indian Fertility Society, Dr. Sonia Malik, my bena. She has made wonderful PCO guidelines. And so past history, physical examination, that is very, very important. If possible, sexually active, you should do pap smear also. Blood sugar, two investigations are there, whether you should do blood sugar and lipid profile. You have to select patients. You can't just in a busy OPD write blood sugar and lipid for everybody. I'm talking of a different scenario. I was at institute, patient population in endo clinic was different. At Paras hospital, the patient population is different. They don't mind investigations, but as judicious. So as a blanket, not every patient should be prescribed a big battery. You have to see her age, her status, if she's fat, has family history, then you go for sugar and lipid profile, and keep these problems may happen in mind. So these two slides are what is the evidence that how and what is must and what is not. So blood pressure, physical examination, they are very important. Thrombophilia screen is not important unless there is family history. Whenever you give somebody OCP or estrogen, the biggest issue comes is thromboembolism, because number of times it has happened with me also. You don't know which patient will have, and it is a kind of life threatening situation. So in this era of medico legal, you are supposed to tell your patient everything and screen them whether there is family history or personal history of thromboembolism. That is very important. If sexually active, pap smear is a good idea. Maybe these guidelines will change since we have started vaccinating all the girls, but for time being, pap smear 3 yearly. Proper patient selection, it is very important piece of information. Please don't write OCPs for very, very young girls who come, mother brings them, iska ek period aaya tha, second has come after 3 months, 4 months. It takes 2 years for hypothalamic pituitary axis to become mature. So there is no need to pump a person with hormones at that tender age. You have to wait on for some time. Just for periods are irregular. I remember when I started having periods at very young age. So once I got the period and 3-4 months it was not there, I was so happy that it will not come again. So you have to be, for 2 years, you should not jump on writing prescriptions. Regular follow-up is very important. After hirsutism, it's the acne. I think I wanted to emphasize, because let aside these slides what is written, we did a project for acne and it is published also, with one arm with cyproterone and one arm with drosperinone. All the patients get benefited. What happens when you start cyproterone containing OCP to every patient? First cycle, it is documented in the literature, there is some flare up. From second cycle on, their skin starts getting clear. And this is very important piece of information. Tell your patient. When I was in busy endo clinic at AIMS, I used to say, this girl is on cyproterone. The skin really becomes very clear after few months of use. So this is a very big advantage. Acne improvement, we will just see some data in the next few slides. So hirsutism, acne. The another very important question is how long and when the effect comes. If you start OCP containing cyproterone, next month the mother comes with the daughter, कुछ भी नहीं हुआ, एक महीना दवाई ली. You have to tell them nothing will happen. Hair growth cycle is such. It will take 3 to 6 months for the onset, and to maintain, you have to give it for long term. It's not just 2-3 months you give and you stop. So that is also very important piece of information, that it takes time for the action to start and you have to give these drugs long term. And if you are giving long term, it's not that OCPs lead to cancer, but if you are giving in little late age people, it's very important. Gynae cancers, three cancers are there: breast, cervix, endometrium, and ovary 4. And there is prevention with OCPs for endometrium and ovarian. But you have to screen properly, because if somebody is going to have cancer and you prescribe OCPs without baseline, then what may happen? They may blame your prescription. So it's very important to do nice clinical thorough examination. This is Foxy Conclave. As Foxy has 29,000 members, I don't think you can make out anything. But the crux of the matter is that when there is hirsutism, OCP containing cyproterone and OCP is the first line treatment of choice. Not that other OCPs do not work, but the efficacy of this anti-androgen and time tested, using it for long, is the maximum. These are our Indian Fertility Society, I think, guidelines. So again, first line is OCP. Acne. Acne, again, cyproterone has been shown to be more beneficial than other progestogens, and you have to give some, as derma prescriptions are very common, topical application, clearing the skin, cleansing the skin, along with that, they are also important. As I said, long term therapy is very important. And when you put somebody on long term therapy, you have to monitor her lipid profile and screen for cancers. And she should not have thrombosis, as I told you. Rarely it happens, but people on OCP. And if it has to happen, it happens in the initial few cycles. That is what is our experience with patients. Now, this is a very nice review by someone who reviewed cyproterone acetate and ethinyl estradiol not in PCO, not in anovulation, only in hyperandrogenism. So they collected all the papers published, and it is quite a recent review. And see in the next 2-3 slides uh, what is the crux of the matter. So it's highly effective in proving acne, that we have already. Percentage changes in different studies were significant, like relief of 53 and 72. And these are the name of the scientists who did either control trials or observational studies. Number of studies, 80-90 studies, this gentleman reviewed, and he came to the conclusion. And this is what, when somebody has this acne, it is in phases. Once there is some swelling, that is comedone, then there is papule, then pustule, then some bacteria come and get into that place, and then it becomes pustule and nodule. So these are the 4 phases. Everybody takes, some give very long term antibiotics, some try to revert the metabolic thing. And but today we are discussing how efficacious is cyproterone in taking care of acne. And this is the crux of the literature. Comedone 24% reduction, 36, 17. So all kind of skin lesions have statistically significant improvement. Maybe it is subjective or objective. All the studies have shown that. And again, these are different statistics just to impress you people, but we are already impressed. We are writing, but still we are reiterating. So the use of cyproterone and ethinyl estradiol, this review said it's highly effective, statistically significant changes, generally seen in 6 to 12 months. This is this gentleman's analysis. Greatest improvements in hirsutism score were generally seen at 12 months, and mean reductions ranging 24, if you continue, up to 54%. It's not that it will just vanish, but it will get reduced. So this is the crux of this meta-analysis. Then this is again very nice meta-analysis, systematic reviews and studies showing cyproterone acetate and ethinyl estradiol containing OCP shows good results for patients who suffer from both androgenic alopecia. And this is the typical alopecia. And you see, we feel that what is great if somebody is alopecia. To my mind, apart from physical diseases, these mental things which give you mental tension, torture, they are more important for mental health. as this thing. When I was a young girl, we friends used to sit in our neighborhoods. There was an auntie who was, now I realize she was full blown PCO, very hefty, very, androgenic type of, and she had so much of alopecia. So my little girls, we were in a bunch, used to say, this auntie is becoming uncle, and we used to sing, this auntie is becoming uncle. How shameful on our part today, I realize. But that auntie must be so much harassed by children doing all this nonsense. So what I want to emphasize, these issues may be very important for people, and I'm not going into pathophysiology, but this alopecia also, there is evidence that with this anti-androgen, really there is statistically significant improvement. And nowadays there is hair transplant also, all these cosmetic things, laser, hair transplant, nothing wrong, they should be done, but both simultaneously have very good additive action. So additional benefits, everybody knows: improvement in menstrual cycle, potential contraception, trend towards improvement in quality of health, and improvement in subjective perspection of psychiatric status. That I think I have emphasized very nicely with an example, and not to laugh, but telling that we should be very sensitive to other people, because anybody can have such an issue. But at the same time, the persons who are suffering, they should be able to get medical help. These are the Indian studies, comparative study, therapeutic effect of what they did. They took three groups. One was given disogastrel containing OCP, one was given dosperinone, one was given cyproterone. It's very interesting observation. Nobody can make out anything. So I'll tell you the conclusion, that cyproterone acetate group showed significant reduction in, as I said, this androgen index, and SHBG goes high. So free testosterone is less, and then uh, action of testosterone is less on the end organ. Then, if you are prescribing something, a very important issue comes in your mind: what are the adverse effects? And it is very, very important. In late age, one should be careful prescribing. Younger patients, nothing much happens. But especially, what is the effect on lipid profile? What is the effect on cardiac status? What is the side effect of estrogen? And these are the few slides. So again, we are in the era of evidence based, so we have to talk with evidence. So effect on hyperandrogenism. So what can you do? The side effects are so rare that even in hundreds and thousands you won't be able to. So you will have to collect for years such big data to come to meaningful that this drug gave such adverse effects. But if you really want to understand what is the damage these drugs are doing, but there was, nowadays with this third and fourth generation, hardly there is hyperlipidemia. This we have seen with, even with dosperinone. So this is another study comparing the effect of combined OCP with low androgen and anti-androgen activities. I think it is quality of life issue. No, this is for hormonal parameters, which I have already discussed. They studied what happens to LH, what happens to FSH. They all get suppressed. E2 should never be below 30. It should be in the range where bone should be maintained, because bones are very, very important, and in old age osteoporosis is a big issue. So that is also a very important side effect, and we should take care. So to conclude, these studies demonstrate that products containing cyproterone acetate have greatest suppressive effect on gonadotrophin E2, indicating that the use of this compound may be a better alternative with impaired gonadotrophins. Then comes the effect of hyperandrogenism. As I said, total testosterone, free testosterone, these things are not even now standardized. You get a free testosterone, it's so expensive, and so many labs will give you so many different. It is in research setting, we did win so many trials, and for a clinician, we measure usually total testosterone. If it is very high, then we say, unless proved otherwise, differentiate from a testosterone producing ovarian tumor, which is very rare, or adrenal hyperplasia or adrenal tumor. Otherwise, in PCO cases, testosterone is always on the upper range of normal. And that is the reason many times, because of want of money, you don't. So another issue is quality of life issue. As I said, we are in the era, we have conquered so much of maternal mortality, we have conquered sepsis, we have conquered majority PPH, our maternal mortality statistics are so good, we are so proud. But these quality of life issues for women, they are very, very important. So what is the effect of these medicines and these drugs on quality life? Quality of life issues, I would just give an example and you will understand. It is very difficult to conduct studies. I was sometime years back a part of an international trial. They were studying effect of a drug on libido in women. Believe me, the investigator said it's so difficult to reach to any conclusion. So people asked why. They said every woman in the West, they have such bad score of sexual performance with the husband, and with the boyfriend and newer boyfriend, the drug works wonder. So what I want to say, quality of life issue is something, our psyche is a very complex thing. But whatever quality of life studies we do, we have to take it. So there are so many confounders. Today you are in what mood, in what, I mean, these things. But quality of life studies have also shown that CPA has more improved in total score of quality of life. So this is the literature, and I think that's true. So this is a Pandora box I'm opening. Cochrane review. Whether you should put a patient of hirsutism on metformin or cyproteron or any other containing OCP, or you should give both, or you should start metformin. If she is not responding, then give OCP, or start OCP, not responding, give metformin. I don't have clear answer because still there are so many trials in the literature and it is not clear. What we practice, if the girl has hyperinsulinemia, if she is obese, metformin helps in reducing the weight also. And these are the clear cut indications. Not all adolescents should be put on metformin. And these studies, I just want to share one or two important points. Crux of these studies is, and it's a nice Cochrane review, that side effects of metformin may be more in like gastrointestinal, like nausea, vomiting, than OCPs. One basic things I have studied in my trials, you give somebody combined OCPs, her periods are regular from the next cycle on. You give metformin, some people respond, some do not. So it's a good idea in a patient who is hyperinsulinemic, you give her combined, but well, so this issue came, so I just put this Cochrane review, and they are also not clear, further confused. So the summary is combination OCP, especially cyproteron containing, especially anti-androgens. Two anti-androgens are in the market, cyproteron and drospirenone containing, have traditionally been the first choice in management of PCO. Cyproteron has been shown to be more beneficial than other progestin, even in Indian conditions, for acne. Acne, though I can vouch. Acne, we did a study and we found good subjective, objective, whatever, with long-term use. Evidence from India comparing these studies. This is a very nice study. I don't know, I quoted properly, that they gave these three OCPs containing anti-androgen, cyproteron, and drospirenone and desogestrel, and treatment difference with CPA was 5 plus, drospirenone 2, deso 1.6. So it scored over. Additional benefits include improvement in menstrual cycle regularity, potential contraceptive effects, all these other non-contraceptive benefits of OCP, which are great. Thank you very much for your patient hearing.